Hi, everybody. Can you hear us okay?
Yes, we are here.
Hi, everyone. Welcome from not so sunny Seattle. Thanks so much for being here. We're over here at Providence Swedish, and we're happy to present one of our Navitor cases. We look forward to discussing that.
Following me?
So,
Let's go to our...
Yeah.
Samir.
Mr. Samir, we have Megan Coloride, Greg Fontana, Isaac George, Andrew Goldsweig,
Yeah.
Jim Hermiller, Paul Mahoney, Giorgio Medranda, and Augusto Pichard, and Firas Zarp.
Perfect.
So everybody's here. Samir, could you start?
You can start present the case.
Yeah,
Thanks.
please.
Perfect. Thank you so much. And it's a warm welcome to CRT, which is one of my homes from my training. So thank you guys for all this opportunity. This case is going to be done by Sidakpal Panaich, my good friend and partner, as well as Roland Hernandez, also my good friend and partner from the CT surgery side. And I'll be helping with the discussion. Next slide. These are disclosures. Next slide. And thanks to a lot of people in the room. So we have our anesthesiologist, David Stout. We have cath lab techs, Gia Pablo Betts, Leslie Rausch, Destin Trudeau, Jean Pack, who is supervised by Jeff Mercer and Melanie Jorgensen. Echosonographer is Carmela Deanna, who's supervised by Brian Durr and Scott Simisich, and all of our cath, echo, research, heart team, and administrators over here at Providence Swedish. Next slide. So let's talk about this patient. We have an 83-year-old male with HFrEF, atrial fibrillation, ICD, CKD stage 3A, prostate cancer, chronic low back pain with severe symptomatic aortic stenosis. Patients on aspirin and apixaban, metoprolol, diltiazem, atorvastatin, and lisinopril. EEG shows AFib with V-pacing. EF is 51% with severe aortic stenosis, mean pressure gradient of 46, ascending aorta of 48. Cath showed some coronary disease, 50% mid-LAD and 40% proximal OM2. CTS saw the patient and said STS was 4.6%, but elevated risk given frailty. Next slide. So let's look at some of our pictures. So here's our area, which is 527, perimeter is 82, minimum diameter is 23.7, maximum diameter is 28.5, average diameter 26.1. LVOT diameter is 25.2, sign of Valsalva and coronary heights were all adequate. We have heavy leaflet calcium with calcium score of more than 3,000. Looking at our access, you can see a lot of the different measurements, but let's focus on the right femoral approach. So the common iliac was 7.1 by 10.4, external iliac 8.9 by 9.2, and common femoral 8.6 by 9.6 with minimal tortuosity. So here's our plan, and we'll talk a little bit more about the Navitor system, but the TAVR with an Abbott Navitor 29 millimeter valve, and you could pre-dilate with up to a 26.2, but we don't have 26.2 balloons. We'll be using a 26 millimeter Atlas balloon. Next slide. So the Navitor Vision valve, it's intraannular, it has a nitinol stent frame, it has a polyethylene sealing cuff, bovine leaflets, and large cell geometry, as well as these vision radiopaque markers, which we believe are very helpful and came out a little over a year ago. As far as the delivery system, we'll be using a 15 French delivery system for this valve, and the minimum vessel size was more than 5.5, and a fully repositionable and retrievable. Next slide. So looking at all of these, I think one of the big advantages from this valve is the commissural height, which we believe will help us for valve-in-valve down the line, as well as also the more cylindrical approach, which helps us with lower gradients. Next slide. Valve sizing, you can see the area ranges from 277 to 707. Perimeter is 60 to 95. Next slide. And then we'll talk about this deployment technique. I just want to spend a couple seconds looking at it. We're going to be pre-dilating with the balloon no larger than the perimeter-derived aortic annulus diameter. And that's new compared to where we were before. That helps us with getting really a good pre-dilation and preparation for this valve. We'll be using the cusp overlap view and removing parallax and using these vision radiopaque markers in the capsule. And then we're using a very slow, steady deployment, getting down to 3 millimeters. If we have parallax, we'll pause or move to the LEO view and remove the parallax, and then moving over to the 80% deployment, and then confirming depth in that view over on the left coronary cusp side, then prepping for final deployment and being very gentle and careful until we get to final deployment. There's a couple new techniques on this that I wanted to also highlight. Another 2 slides here. So next slide here, or actually last slide. So imagine as we're, go back one. Bias maneuvers right there, right here, yep. So imagine as we're deploying, and this is an important thing that we've learned with this valve, if the left or the non-coronary cusp is deep, our maneuvers are going to be pushing the wire or pushing the delivery system to the outer curve. If we go to LAO, or as we're working to LAO, it looks like it's going to be shallow, then our plan is to either pull the wire or pull the delivery system to the inner curve. And we just wanted to highlight this on PowerPoint before we ended up going to our case. Thank you very much. Let's go live.
All right, thanks, man.
All right. Can you guys see the flow here? So,
Samir, before you start, you want to talk to us about the ceiling of this device? I mean, on this version of the Navitor versus the first generation of the Portico?
Yeah.
No, absolutely. So one of the advantages that we've seen here using this is that with this polyethylene skirt, both internal and external, it's really an active leak mechanism. So to me, I kind of look at it as kind of every beat stops the leak. And so as we saw in the animation, as there's diastole and the blood's coming back, it fills up this cuff, which helps decrease paravalvular leak pretty well.
And is a pre-dilation mandatory for every valve, and how do you size the balloon pre if you do it mandatory?
Yeah, great question. So I think Bassam, who's one of the people that has really helped pioneer this as part of the Envision trial, has also helped us sort of understand that pre-dilation is mandatory for all of these cases. In addition, it used to be we would come from an area-derived diameter, but we realized that that wasn't enough. We're moving over to a perimeter-derived and really getting to a point where we get a good pre-dilation. In this patient, for example, what we saw is that the annulus perimeter-derived diameter would get us over to a 26. We do have an LVOT of 25. So we went back and forth as to whether we should use a 25 balloon versus a 26 balloon, and we elected to eventually use a 26 Atlas balloon to give us a really good pre-dilation for this case.
All right, guys, we're going to be pre-dilating with a 26 balloon. We have an Atlas here. It's not my favorite balloon. I only use it for fractures, but in this case, as you know, post-COVID, you get what you get. And so we have a 26 Atlas. So I apologize if we take an entire 45 minutes for this balloon to come down. 120 pacing, David.
Do you ever consider having the balloon higher so it's not so much in the LVOT?
Yeah, we're going to adjust this right now. Yeah.
And generally speaking, do you do pre, but do you do post as well in this?
Yeah, great question. We usually end up with a really good pre-dilation. We've seen very minimal need for post-dilation, but definitely something you want to keep evaluating.
I mean, to your question, Maurice, it's not mandatory to do post-dilation.
Right. Again, I'm asking, is it maybe doable, or how many people do it? Percentage.
Only if you need to. If you need to, you do it. If you don't, you don't.
30% of the time.
Yeah. So we'll have to go faster. It's kind of moving a lot. So.
And at this point, the Navitor is ready to go, just in case. Again, I don't recall a case that it was happening, but if you have severe AR, then you're ready.
Correct.
160, please.
Yeah, the Navitor has already been checked and is ready to go.
And the more generous your pre-dilation, the less likely you are to need post-dilation. So it seems reasonable to go with the 26 here.
And with respect to the comment about the AI and the cuff and the active cuff and the AI, also compared to the original platform, this one, the radial strength is better. It's, I think in many ways it's far superior to the Portico.
So if you had a choice of another balloon, would you use a true balloon here? Because
just because like, you see how it's tough to get this.
It's a tough balloon.
I love it for fracture for the same reason, but for
what balloon was this one?
It's Atlas Gold.
Atlas.
Yeah, Atlas. Yeah.
Samir, at the meeting, it's been a theme about the importance of pre-dilatation in some of these newer platforms, and I think thank you for illustrating how it can sometimes be challenging.
Yeah.
Mm-hmm.
Yep.
So
just 180.
So this patient is a high-risk patient. That's where the approval right now, and there's the Envision study for the low risk and moderate risk that is ongoing. So this patient is a high risk. Is that correct, or extreme risk?
Correct. High risk.
All right, guys, finally got a good.
Yeah.
That was a good dilatation.
Image, yeah.
Your pressure's coming back nicely, so unlikely to have significant AI with this.
Yeah, there you go. So this is what we wanted.
And Samir, one more point. This patient already have a pacemaker. So do you use the pacemaker for pacing, or you use an extra? I see here you use a pacing wire, but do you consider to use a device on top of the pacemaker?
That's That's an interesting point because our normal practice is usually one radial access for a minor access. We use one femoral for a major access. And then as far as the pacing, we're predominantly LV pacing shop. And so when we started working with Navitor, one of the things that we realized is, yes, you can do LV pacing. We don't use the pacemaker predominantly. In this case, because of the large size of the LV, what we noticed was that with the large size of the LV, sometimes when you do LV pacing, by pulling the wire back at various points to centralize, you may lose contact. So with that in mind, we ended up using a temporary pacemaker for this case for ease of use.
All right, guys, we're exchanging the sheath out. So you want to talk about the inline versus the sheath?
Yeah, the integrated sheath is an important aspect for this self-expandable valve. And so what we've seen here is that we don't use an additional sheath. We're able to cope under above 5.5 centimeters pretty well. And this patient still has, we could have used a sheath in this case, but we elect to often just do this with using the integrated sheath platform and have had pretty good results.
And I assume you pre-closed this groin prior to getting the first.
One of the things, one of the things that you also see here.
Or two proglides?
Yeah, two proglides. We're using, he's turning the flush port up to 12 o'clock.
You guys see this right here?
And with the advantage of that is that by doing that, we hope to decrease any risk of misalignment on the coronary aspect.
Well, you have markers that will help you set the valve.
Mm-hmm. Absolutely.
Yeah, one thing which is unique for this valve is the trackability and the flexibility to go through tortuous aorta or iliacs.
You're open?
It is very remarkable that you can,
you don't
navigate these big turns. And the other thing is you can really deal with horizontal aortas without any issues, I think, in part due to the flexibility.
So this is the idea, is the flexibility is what your thoughts are.
So what are you testing here? You're showing on the fluoroscopy. What is that you need to see on the valve?
Let me actually mag in here. I'm going to
if you can zoom, there are some dots there, right, at the markers that you look into.
Yeah, so let me just actually, if you guys can see it forward.
So you're thinking about, most importantly, is the flexibility of this. That's the idea.
Right. So guys, just like we did for the other self-expanding valve, what we're looking for is, like you see the two markers, the vision markers there, the three big dots that you can't miss. And so the two are on the outer curvature. That's what we're looking for while we're here in the descending aorta. And then one on the inner curvature. So that allows for commissural alignment when we actually get into the deployment stage. So that's what we're looking for here. You guys can see that?
In all these, you need to be in the LAO to do that or it won't work.
Yes, we're in the LAO right now, exactly right. All right, so we're going to cross over. Let's go there.
Are you seeing the markers? Can you see the cup markers?
Yeah, you can see
yeah, it's adequate. And you look at the flexibility of this cutter as it navigates the arch.
I'm looking for the max. Marshals. Where is it?
Bob, could you put on the anesthesia vitals on our screen?
Let's go over here. Cusp overlap, please.
I see it.
So you'll swing to the cusp overlap view just as you get ready to deploy? Is that your plan?
Yeah, I'll talk about that. So the cusp overlap view is going to have the left and the non over on the right side of the screen. The left and the right on the right side of the screen, and the non over on the left side of the screen. The goal is to put the pigtail in the non-coronary cusp, and then we're slowly crossing, and then putting the valve in the correct position here. So the advantage of doing this cusp overlap view, I think about 4 or 5 years ago, came from another self-expandable platform, but it's been used for pretty much all the self-expandable platforms here, is the goal is to really help optimize depth. And we'll talk about the markers here, as we talked about a second ago. The markers are going to be about 3 millimeters, and 1.5 millimeters long, and they're 3 millimeters high. So you want to land with the marker at with the valve about 3 to 4.5. So between the bottom of the marker and the top of the marker at the base of the pigtail is our goal.
Okay, so at this point, we have taken no pictures whatsoever. We're going to take the first one at right coronary cusp, make sure that our pigtail's at the bottom, and we'll start there. All right, Leslie, inject.
Yeah, the markers are now easier to see.
You see there's a heavy leaflet calcification, so our pigtail is not exactly at the bottom of but our stent frame, which should be lining up with the annulus at the right non-coronary cusp, it's actually lined up pretty well, just a little bit below the pigtail. So we're going to start there and let that valve kind of come down as the capsule goes up. And then we're not pacing at this point. We'll start pacing once we get to about 23%.
Sid, you did something pretty amazing. You put that pacemaker wire right at the annulus. So
and that's like the other thing that we do at Swedish. So.
Yeah.
We use the pacer, but when we use it, we put it right there.
And did you bring the wire back a little bit there?
Yeah, we're going to bring it back just.
That's a good idea.
That's exactly right. So once the capsule that gets up there, then we're going to bring the wire back.
What's the best millimeter position into the LV? How does it look like?
Higher as possible you can.
The highest, like
Higher the better.
Yeah.
So the same thing. 1 to 3 millimeters.
So you guys see it's kind of diving in a little bit. I'm going to pull back a little.
Yeah, you're a little more than 4.5 now.
These markers have been really helpful because they're really easy to see, and you can't, if you're below 3, you know it.
Yeah, clearly,
So guys, at this point, we're staying in in this cusp overlap because we don't have any parallax. So I'm going to keep deploying, and once I get to this point, I'm going to start pacing. Dr. Stout's going to start pacing at 120. Inject, please. Let's start. Andrea, like it? Yeah. Start pacing 120, David. And so I'm going very slow, as you guys can see. I'm just going like one turn. Like this, Samir?
And for commissural alignment, how late can you rotate the valve?
It's too late.
Yeah,
now.
great question.
Descending.
Yeah, it's too late.
Yeah.
It's probably the best time to do it would be at in the descending aorta.
Yeah, no, we did that. So
No, I know. What he was asking is how late is too late.
Oh.
Yeah.
There you are.
hard-
It looks
very
like you're
hard
right
once
about
you're
3
in the descending
millimeters
aorta,
below the
and
pigtail.
impossible once you're in the valve.
All right. Inject. I like that, guys.
It's really high now.
That's not really that high.
But,
It's going to rock over. I think you're in good shape.
it may dive a little bit by itself. You're getting close to the first stop, right?
Yeah. So right now he's in the ariocaudal view. Let's see how much parallax he has. Do you want to?
Yeah, just go LAO. We have a little parallax. Let's start rolling over LAO, guys. Yep.
Well, you have a lot of experience with this valve. Are you going to move it at this point, or you
There we
happy
go.
with the position?
I like the position here. You got to make sure we capture the left side, and they're taking care to make sure they do that.
Yeah, you're good at the non-coroner, no doubt about it.
It deploys a little different than.
But you have to do
than
it on the LAO view, right? You're not on the LAO view yet.
Inject.
We just took the parallax out. We're not very LAO. We're LAO 8, caudal 28 at this point. Do you guys feel we need to be more significant LAO at this point, or is this good enough? That's one of the questions that we sometimes ask ourselves.
As long as you line up your dots, get the parallax out, you're going to be okay.
Yeah.
That's what we think too.
All right, go a little more LAO.
Is this high enough?
Maybe too high, let's see.
Yeah, maybe.
Oh, no, I think you look
this is
fine.
good.
I will take a
I think
picture
it's going to be
Inject.
perfect.
Looks perfect to me.
One vote
You
for
look good.
perfect. Yeah, looks good.
That's okay with this.
Remember that dot on the left goes from 3 to 4.5, and so you're right at the top of that. So on the left, you're 4.5. You've got plenty of room there.
Yep.
And also, as you're pulling your wire back, you really are nicely parallel with the long axis of the aorta.
And notice how he's deploying slowly. See his hands.
We're just spacing at 120, so we're relatively stable. Our valve is already functioning at this point.
It looks like you have annular contact.
Yeah, you have annular contact, and now you've got not a lot of blood pressure. So now is the time to
Yeah,
get
the
to the
hemodynamics
80%.
is still under.
Yeah, it's still 70 over 48.
All right, we can come off pacing slowly, please.
I think this is just one of those patients doesn't like a lot of RV pacing. So he's slowly getting better with pacing coming off. Store that. So at this point, what would you guys do next? What's normal practice in your guys' labs?
It was impressive to see how stable the valve is as you were deploying it. It wasn't moving up, wasn't moving down, perfectly stable.
Put your
Alright, so
LAO view and take a picture.
Yeah, we'd like to see the LAO.
Yeah.
I think Paul's point about really seeing the left is important. It's common that you open up and you're way too high on the left. You don't think you are, but I think going early to the left orientation and then doing that shot really lets you know that you're in the right place earlier rather than fully opening and then realizing you missed the left. So.
And there I'm seeing you take the caudal off. That's to get the parallax out, and you see the markers line up nicely there.
Yeah.
It's still off slightly.
Yeah, let's just come just a touch caudal more. That's good. I'll go more little that layer. That's good.
You can see this is pretty horizontal. I mean, it's more horizontal than you would have imagined, right?
You like that, or is?
Yeah.
All right, we're gonna take a picture here, guys. Leslie, inject, please.
Hold your breath.
Yeah,
Makes your left look a little high, doesn't it?
So here's the question that comes up: is that at this point, do we want to pull the valve and try to tilt it, or do you guys think it needs to be recaptured?
I don't think the parallel.
Greg Fontana, what is your call? You stay here or you move it a little bit down?
Tilt it. If I'm comfortable that we're 25 LAO and the parallax is out and I've got a couple of millimeters on the left, I'm comfortable. I'm feeling a little borderline here on the left right now, at least the views they've shown.
Yeah, we are almost on ground zero there.
All right, we're gonna take another injection here, guys. Inject.
So the marker is above, but
of the valve, because
I think you're okay, Greg. You're gonna rock over to the lesser curvature. It's gonna come down. I think the annulus is a little bit higher than the bottom of the cusp you're seeing.
Yeah, I agree. This
right,
view is
so in the
more encouraging.
You want to go to the
so
overlap?
Hold on a second. So from a panel standpoint, if you had to vote,
you got the permit to deploy.
Is everybody saying? Everybody saying to recapture?
Yeah. If it's too high, it's on us.
go Gus Broussard slow. That's Gus Broussard slow.
Yeah,
that's where I was going.
But it will rock over to the left with deployment. And
vision markers right.
Rapid pacing may help.
So rapid pacing during deployment?
Yeah.
How rapid? Are you talking 120, 180?
180.
180.
Yeah. Samir, the other nice thing is you don't see leak here, so wherever you're at least sealing pretty well.
Okay. Right. We have one injection left. Let's actually change out the injector. Sid, what do you think about that?
No, I think what we're gonna do is I don't think we need more injections. I think everyone's happy, right?
Yeah.
That we're just gonna go right cusp overlap here, show you that we're still nicely. We're not gonna take an injection, just go by the pigtail. And I don't think we need another injection, just the last one, yeah. So we're gonna pull the pigtail back after that, guys.
Yeah, your markers are well oriented with respect to cusp overlap.
Yeah. All right.
And the other aspect is that we have pretty uniform expansion. I know we didn't discuss that, but that's another thing that's an important point for this case.
Go back to
that's because you had great pre-dilation 3 times.
Mm-hmm. All right, so let's go LAO 40.
The other thing is to look that there is no bunching. I don't see anything right now. It's maybe also due to the pre-dilation.
No, I tend not to rapid pace. This valve is heavily calcified. It's not moving. I think this is a nice valve to deploy without pacing, unless you really see a lot of movement, like a patient with the AI, for example.
So he's pulling the pigtail at this point?
It's essential.
So this valve works in the heavy calcified milieu, right? Leaflets and.
As long as you aggressively pre-dilate.
David, let's space at 140, please.
But it was specifically designed with radial strength in mind, so it really does handle calcium nicely.
Neutral.
Mike Reardon, radial strength, Navitor versus Corvalve. Where are we standing with that? Is that similar, less, more?
Corvalve has a little more, but it's really not a lot more. It has a little more because the diamonds are smaller. The smaller your diamonds, the more radial strength you get out of it.
But it's more nitinol.
But
it's more nitinol.
The final radial strength is the same. So during deployment, it's less, but once it's expanded, it's the same, as I understand.
Well, yeah, so there's opening force, there's radial force, and there's hoop strength. And so each one of those is a little bit different, and it has more opening strength and a little more radial force. They both have hoop strength once you get them out to where they need to go. But the more nitinol you put in there, the more radial strength you're going to get. That's just the way it works.
So it seems like the valve rocked a little bit in a favorable position.
Yeah, it looks better.
Yeah.
What do you think is better with this nitinol? Why do you think it is better than?
Again, I hate it when people ask me which valve is better. I mean, that's like somebody asked me which of my daughters is prettiest. You know, there's no answer I can give that's not going to get me in trouble with somebody.
That's why I asked you for.
All these
All right, off facing, please.
valves have,
Yes,
pros and
yes,
cons to them.
yeah, stable it was.
You can put Cine on. Just put Cine on.
Yeah,
to
it is
show
a very
everyone.
good choice for extreme and high risk right now.
All right.
Data support this as well.
It did rock nicely there.
Or for
toward
those in the
left
trial,
cusp.
remember low risk and intermediate risk, please enroll.
And the other comment is the valve areas and the gradients you get are evolute-like when you go back to the randomized trial and of Portico. They're very good, although this is an annular device.
It's going to end up pulling out the whole system here, just as opposed to playing with the wire a bit. And that's just one of the things to.
It's got to come out, as you guys can do it. Just
Yeah, it should be out now.
yeah, slowly. So I was trying to save the wire, but it was pushing me to the outer curvature. So I was afraid that I didn't want to catch the nose cone on the.
Yep.
So I just ended up pulling the wire into the nose cone and taking the whole thing out.
So after this, what we'll do is we'll do an aortogram. We'll also check on echo, and we'll share that with you.
All right, let's just save it.
Pressure looks great.
Yeah, it's hard to
pressure's
see
fantastic.
conduction issues here because of the quality of the. What do you see in terms of the
I see
conduction?
pacers, it
You
doesn't
have a
matter what its
pacer
conduction
anyway,
is.
right? So you're good here.
Yeah.
2 pacers, just in case.
All right, that looks. All right, ready for injection? Inject. You guys know AI, at least on
Yeah,
Android.
that's the beauty
Beautiful
of
That's the
result.
biggest.
ceiling.
That's the biggest thing I'm seeing it with self-expanding.
Yeah, echo's next.
There's not much leak. That's very important.
No
and
leak.
different.
No leak.
Yeah,
That's the difference.
yeah. The ceiling of this valve is unique. I think it's.
And that's what the advancement of this self-expanding system.
But it depends on the really ceiling. I mean, this ceiling is really.
Let's see
robust.
echo on our screen, Bob. So first things first, we'll see the echo here. So no effusion, which is great.
Samir and Sid, I'm curious if over time you think there'll be less need for all of the fluoroscopy that you did with this valve. I know it's in part for teaching, but certainly it seems like it's pretty intensive with regards to following the deployment.
I think, yeah, Sid, what do you think?
I think so, Megan. Usually I would tell you we have done a little bit less, but I think with the Envision trial going on, we're trying to also showcase the IFU, which the Abbott folks are recommending, and they've come up with this this protocol for the Envision trial itself. So they want us to get measurements and different views, make sure we're well expanded. There's no non-uniform expansion, and then we're kind of rolling over. So I totally agree with you that that probably half of this might not be eventually necessary, and we could skip steps on some of them as we get more and more information. But at this point, we also kind of wanted to showcase exactly how we want everyone to be a part of the Envision trial to be kind of deploying the valve per IFU.
On
I
echo,
think
the valve seems symmetrically expanded. Can you show us on fluoro in two projections?
Yeah, we will. As
Yeah,
soon as,
without
we-
that, just to show the frame.
Yeah, we'll
180
show you
degrees
that
swing.
last. We'll do that
The
as
thing
soon
is,
as our.
look at the
our
long
first
axis.
steps away.
Look at the long axis, no color. You're deeper than you thought you were. So you have plenty of depth there. You're
Yeah.
always a little bit deeper than you thought you were on the long axis.
Yeah, it was a good call in terms of the height.
Yeah, you should take it back.
Wanna get it?
Yeah, that's exactly.
So on echo, what you saw there is a trace to mild leak at most. Which what's our pressure? What's our systolic there, David? What's our pressure? Yeah, it's 100/46. And as from an expansion standpoint, Gio, do you want to show us a kind of a run going from LAO to RAO just to show the expansion?
All right, ready? All right. Let's get back.
What's happening with the rhythm? We can't really see the EKG. Is the patient pacing or is this native?
Well,
Well,
the
patient
patient's
has
got
a
a
number.
pacemaker.
It was a
so-
pacemaker.
Right, but is the patient pacing or is this
Yeah.
native conduction?
Yeah, the patient is because he's a CRT device, so he's
Ah, okay, so it's 100%
that's what he
paced.
benefits. Yeah, so he had a so he's actually benefits from the IV. All right.
Yeah.
ready? All right. So you
So Mike Reardon, you want to talk to us about, or maybe Greg, there was actually a study randomizing to the other valves that are approved, right? It met a non-inferiority in this category of extreme risk?
Yes.
Yeah, well, Greg,
Yeah,
that's your
Portico.
trial. Yeah, so
was-
Greg,
yeah.
Greg can talk about that.
That was the Portico IDE. So yeah, it was non-inferior to the commercially available valves, and so that was the first generation Portico. Then we moved into second generation, and now really the third with the additional addition of skirt and the vision dots. So, but right now we're still running the trial for. Well, then Mike took over for the next stage, which was the high risk trial for the current valve platform.
Yeah, so there's two trials. One, Europe is Vantage, which is a single-arm trial, low risk intermediate, and the FDA demanded we randomize them. So Envision is the U.S. trial randomizing against commercially available low and intermediate risk. It's filling quite well. It's been gratifying to see it.
I'm going to switch you back.
Yeah, so if you watch the factoid, you can see all the details on the valve. And what I was impressed with this one primarily is the active sealing cuff.
I thought this is what, for me, it's very big deal.
Pacemakers out.
There is something in this cuff that really seals nicely. We don't see much leak with those valves.
Yeah. From our standpoint, we're very close to giving protamine and finishing up. Is there anything else that you guys want us to focus on or see before we give protamine?
I'm going to pose a question to Dr. George Isaac. We do need another valve. We have now 3 approved valves for TAVR for extreme risk. Is there any room for another valve to come here? And then maybe, Firas, you want to follow what kind of other technology that are in the pipeline that would make it attractive for a next valve to come into the market?
I'll answer. I think there's always room for new technology. Technology will drive us forward. We have to try new things, and we can't accept the status quo of where we are with durability, leaflet function, valve performance, conduction, coronary access, alignment. All of those things can be improved significantly with all of the valve systems. So I think there's a lot of room for next generation valves to add on to the learnings that we have. I think there's a huge field of new leaflet technology that's actually the next step of what the iteration should be to get to surgical-like performance in a minimally invasive system.
Yeah, unfortunately, how many people can use it? How many can we use?
Ready?
Firas, anything to add to new technology?
I mean, this was a fantastic case. Congratulations to this Swedish team. I mean, the challenge for for TAVR valves right now is that we're moving towards younger and younger patient population. So the issues with coronary access, durability, as well as the valve-in-valve. I think all of those are the crux of where we are as we move toward younger and younger patients population. The technology is there, and I agree with Isaac. We're always welcoming troubleshooting.
We are not done.
We're not done.
Yeah, unfortunately, how many cases you can use with patients, for example, in the US, how many valves can you have? How many can buy? It's like, how can you do it?
But Maurice, you not have to keep the old valves. You're just replacing new technology.
But how many? But you've learned it. People have understood it.
Okay, well, let me point out that there's twice as many TAVRs done as surgical valves and 10 times as many surgical valves as are TAVR valves. So we manage it in surgery with a whole lot of valves. What we do is we find the mechanical valve you like, 1 or 2 stented tissue valves you like, and the root valves you like. And I mean, really, we do half as many cases, and we have 10 times more valves than you guys.
I have a question about the sealing skirt I'm going to ask Greg about. We've talked a lot at this meeting about the risk of valve thrombosis, and it just looks like a spot for stasis. Can you tell me about your thoughts for that?
That's a great question. Don't know yet. I suppose it's interesting. This valve, as you can see, the active skirt opens and closes, and the question is, will that mechanism be in place down the road? My thoughts are it'll probably be incorporated into the healing process and become immobile and be fine. I think the question also came up with this trial when we talked about should these patients be anticoagulated for 3 months because we're introducing a very new concept. The decision was no, just to keep it going as we have in the past. And so far, there hasn't been any indication that there's been a problem with perivalvular clot and subsequent emboli. Mike, you may any thoughts on that?
I think, yeah, I don't think we're going to see it. I've taken some valves out and found clot behind the native leaflet when I've done TAVR explant, but it was trapped back there and just was sitting. It's an interesting question, but
that's in the neosinus, though. Yeah.
Greg, one important reason to consider it is the whole concept of slight asymmetry in the valve could contribute to deposit of platelets, red cells, fibrosis, eventually clot.
That is one thing you do have to consider with an intraannular valve, that there are eccentricity ratios that you really don't want to go across because it is going to sit in the annulus. And you can reach a point where you'll be too eccentric.
Get another per close, please.
But I was going to say, how many per closes? I saw you put an angioseal. Was that in the big one or the little one?
In the big one. So the big one looks fantastic. I think we had 2 per closes, and we end up going with an angioseal. So there's patients that we can do an expedited discharge pathway. So we focus on getting as good groin closure as possible. So it may be a little bit of a big step, but sometimes even just adding an angioseal just helps everyone on the floor feel more stable.
And what's expedited? When is he going home?
We don't. What do you think, Sid?
Today.
Well, it's 7:30 right now in Seattle, so you're early in the morning.
7 hours.
You have the whole day in front of you.
Yeah.
And he has a pacemaker.
Yeah.
And he has a pacemaker. He has excellent hemostasis. And we get this venous side, this radial side all taken care of, the guy should be able to go home today.
If he was a low risk, I wouldn't bother. But you never know the high risk. If they have other comorbidities, you have to look for that.
This patient is very sick in many ways. Yeah.
Can I ask a question about the intravalvular leaflets here? In terms of lifetime management, I wonder if folks have thoughts here about the large diamonds and the intravalvular leaflets. It seems like perhaps part of the design here is looking ahead as opposed to other self-expanding valves, forward thinking for a future procedure.
So there is long-term data with the Portico over 5 years, right, Paul? You presented some of this last year at CRT.
Well, it's not just not just that. It's you can model how likely you are to get a second valve in there. And I mean, I think that's the real key is that you can take your first valve and model whether or not you're going to get a second valve in there or not. And everybody's looking at that right now.
So, Mike Rudin, I'm going to ask you a tricky question. I know you're the PI of the Envision study, moderate and low risk, and the enrollment is going, but long road. So is it possible to go to FDA with partial of the data based on all the information that we have? Eventually, we'll have the post-marketing data, we'll have the study data, but if in this rate, we're going to take probably 2 years before we're going to get the approval for, this is just expanding labeling. This is not about a new valve. So is there anything in the horizon to expedite this process?
Well, first of all, I'm not the PI, I'm the chair. I'm too old to be a PI. Chair should be people in their mid-career where they can really benefit from it.
But
and I don't know, if the FDA will give us an early look, then the answer is yes, but they're not usually very keen on that unless it's built into your statistical protocol, as such as an early Bayesian analysis. So I doubt we're going to get an early look at things. Although I'll tell you the last couple of months, it seems like, and Greg will tell you this, because Greg runs screening, that our enrollment seems to be picking up again.
How far along are we in the trial?
We're about, I think, 40%, close to there. I mean, don't quote me on the exact number, Gus, but we're getting close to half.
Hopefully less than a year from full enrollment, but that would be optimal if we follow the optimal line.
We have about 3 more minutes left, or 2 minutes left. Any questions, discussions?
So there's a trend towards more aggressive pre-dilatation in these self-expanding platforms. I think without question it helps with the implant initially, but it's a self-expanding platform. One of the advantages is lower risk of annular rupture. You think we're trading risk of annular rupture for ease of implant? If we want to put a 26 balloon in, maybe we should, there's other platforms we can do that. Is anybody worried about the increasing balloon size? I guess we'll see if there's a higher risk of annular rupture.
Probably doesn't happen.
If you stay below the mean size, the mean diameter, there should be no risk.
I don't think, Paul, at the level of the balloons we're using, I don't really think that's the risk. I mean, the decision making is based on some other things, how you feel about the device, coronary access, hemodynamics. I mean, I don't think, I haven't seen an annular rupture in several years now.
It happens still with
Okay, we have one more case to go today, so.
Yeah, so
don't
thank
ding
you
it.
very, very much for you have done. Excellent presentation.
Beautiful work, Samir and the
Excellent.
team in
Samir,
Washington.
be well. So thank you very much again. So next step.
Coming next is the tricuspid
Yes.
repair and replacement, so that will cover all the topics. And Azim Latif was willing to step into the state of the field of tricuspid.
Thanks, everybody. Nice work, everybody.